Dear colleagues, my name is Kalliopi Keramida. I am a consultant cardiologist in General Anti-Cancer Hospital Agios Savvas. And today with my colleague, Dr. Dorothea Tsekoura, we're going to talk about cardiotoxicity in elderly breast cancer patients. So breast cancer has become the most prevalent form of cancer worldwide. Every 14 seconds, a woman somewhere in the world is diagnosed with breast cancer. The occurrence of breast cancer is strongly correlated with age, with the highest incidence rates being observed in older individuals. According to the National Cancer Institute, it is most frequently detected in women between 65 and 74 years old. The overall rise in breast cancer incidence with age can largely be attributed to the accumulation of DNA damage in cells over time. This damage can arise from biological processes or exposure to risk factors. Breast cancer is the leading cause of death in women younger than 60 years and the second cause of death in women aged over 60 years. As women age, the mortality rate for breast cancer increases. In those older than 85 years, the mortality rate is approximately 13 times higher compared to younger age groups. This worse outcome may be related to undertreatment, delays in treatment, and cardiotoxicity. Age is an important risk factor for the development of cardiotoxicity during or after breast cancer treatment, accompanied or not by comorbidities like hypertension, diabetes, dyslipidemia, or established cardiovascular disease. So, baseline cardiotoxicity risk is a priori increased in this population, and the range of cardiotoxic effects in elderly breast cancer patients is wide, including not only myocardial dysfunction and heart failure, either with reduced or preserved ejection fraction, but also hypertension, arrhythmias, pericardial diseases, and thrombotic events. The cardiotoxic effects of anthracyclines are the most widely explored, and clinical studies have shown that elderly are at increased risk for cardiotoxicity in comparison with their younger counterparts, even at lower cumulative doses of anthracyclines. Several reasons could explain that, including, but not limited to, age-related loss of cardiomyocytes, altered pharmacokinetics of anthracyclines during aging that result in increased anthracyclines concentration, constellation of comorbidities and polypharmacy that may lead to drug-drug interactions, frailty, and worse performance status. However, despite the increased prevalence of older adults diagnosed with cancer and associated treatment toxicities, seniors are underrepresented in major clinical trials, justifying absence of evidence-based surveillance and treatment protocols for this particular population. Dr. Tsekoura, would you like to discuss some of the studies that assess cardiotoxicity in the elderly breast cancer patients?
Of course. Hello, I am Dorothea Tsekoura. I am a consultant cardiologist from National and Kapodistrian University in Athens. And I have to admit that only a few trials are dedicated to the assessment of cardiotoxicity in elderly breast cancer patients. In 2007, Pinter et al. Investigated the long-term cardiac safety of adjuvant anthracycline chemotherapy in more than 43,000 women aged 66 to 80 years with breast cancer. They discovered that women who received adjuvant anthracyclines had significantly higher risk of congestive heart failure compared to the chemotherapy agents, to other chemotherapy agents, and this risk continued to rise over more than 10 years of follow-up. The risk of CHF increased with age, black race, trastuzumab treatment, hypertension, diabetes, and coronary artery disease. Another study by Serrano examined trastuzumab-related cardiotoxicity in elderly breast cancer patients with median age of 75.9 years. The study found that a small percentage of patients experienced asymptomatic cardiotoxicity, while a smaller percentage developed symptomatic cardiac heart failure. Patients with trastuzumab-related cardiotoxicity were more likely to have a history of cardiac disease and diabetes. The study suggests that elderly breast cancer patients with these risk factors should be closely monitored for cardiotoxicity when receiving trastuzumab. In the same line, Chen et al. Proved that in older women with early-stage breast cancer who received adjuvant trastuzumab therapy, the adjusted 3 years incidence rates of heart failure or cardiomyopathy were higher in patients receiving trastuzumab or anthracycline plus trastuzumab compared with no adjuvant therapy. While the addition of trastuzumab or anthracycline therapy increased the number of heart failure or cardiomyopathy events per 100 patients over 1, 2, and 3 years of follow-up. The study concluded that heart failure or cardiomyopathy are common complications after trastuzumab therapy in older women with higher rates than those reported in clinical trials. Savvas, McGregor and colleagues confirmed the increased risk of elderly women with trastuzumab to develop CHF, but also identified older age, coronary artery disease, hypertension, and weekly trastuzumab administration as important risk factors. Having realized the increased risk of heart failure associated with anthracycline, Gill et al. In 2014 conducted a study to assess the feasibility of using pegylated liposomal doxorubicin, PLD, in elderly women with stage 2 to 3B breast cancer and at least one risk factor for developing cardiotoxicity. The results showed that PLD was viable in a fragile patient population that was not suitable for conventional doxorubicin. Close cardiac monitoring was conducted throughout the study. Collectively, this study suggests that cardiotoxicity is a significant concern for elderly breast cancer patients undergoing treatment. The risk factors for cardiotoxicity include comorbidities, pre-existing cardiovascular disease, and age. Further research is necessary to gain a better understanding of the potential interventions and risk associated with cardiotoxicity in elderly breast cancer patients.
Coming to prevention, a thorough assessment of the elderly women with breast cancer is imperative, including a cardiological but also a comprehensive geriatric assessment. Genetic testing could also help to identify women in high cardiotoxicity risk from anthracyclines. Rigorous screening would help to exclude patients at unacceptably high cardiac risk from potentially cardiotoxic therapies, paving the way to alternative therapeutic choices like liposomal doxorubicin. For the rest of the patients, optimal risk factor control, cardioprotective medications if indicated, appropriate choice of the specific anthracycline agent, and respect of the recommended upper cumulative dose in association with frequent and strict cardiological surveillance may protect them from developing cardiotoxicity or at least may enable diagnosis at an early and potentially reversible stage. Under no doubt, we need more studies to identify the best surveillance and treatment strategies in this vulnerable population. And here comes CARDIOCARE.
CARDIOCARE project represents an interdisciplinary approach for the management of elderly breast cancer patients. Lack of best practices and frailty bias in these patients that are underrepresented in clinical trials may lead to inappropriate interventions and other treatment resulting in poorer outcomes, deterioration of quality of life, and increased healthcare costs. The EU-funded CARDIOCARE project that focuses on the elderly breast cancer population through a holistic approach, including a e-health application, wearable sensors, echocardiography of course, and biomarkers. In this way, it gives to patients the opportunity to take part in their care process and enhance their physical and mental health, contributing to an individualized care plan and psychological adaptation to their disease. CARDIOCARE will potentially enable effective risk stratification, mitigating cardiotoxicity and adverse events minimizing hospitalization and enhancing quality of life.
We're looking forward for the results of this trial.
Of course.
Thank you very much.
Thank you.